On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Nelson Trujillo. Board certified in cardiovascular medicine, nuclear medicine, and internal medicine, Dr. Trujillo is a graduate of George Washington University's School of Medicine in Washington, D.C. He did his undergraduate work at Tulane University in New Orleans, Louisiana, earning a bachelor's degree of science in engineering. After med school, Dr. Trujillo spent much of the 1990s at the University of Colorado Health Sciences Center in Denver, where he completed his residency in internal medicine as well as fellowships in cardiology and nuclear medicine. Dr. Trujillo sees patients at Boulder Heart in Boulder. Welcome, Dr. Trujillo.
Well, good evening, and thank you for the very kind introduction. I have to say this is always a little disconcerting for me. I'm speaking to you live from the Leo Hill Conference Room here on the campus of Boulder Community Health, and nobody else is here in the room with me, so it's going to be one of those nights. So if my jokes are bad or if this isn't going well, please throw the tomatoes directly at the screen, and I'll try to duck. I'd like to start off my talk this evening with a poem. Many of you who know me know I'm a fond of good poetry, and it's always nice to start out with something a little light as we spend this evening together talking about heart disease. And so the poet I chose is Charles Bukowski. He's known as the laureate of American lowlife. I think he was sort of immortalized in the movie Barfly by Mickey Rourke, but a pretty well-known contemporary American poet. And the poem I chose to read tonight is The Laughing Heart by Charles Bukowski. Your life is your life. Don't let it be clubbed into dank submission. Be on the watch. There are always ways out. There is light somewhere. It may not be much light, but it beats the darkness. Be on the watch. The gods will offer you chances. Know them, take them. You can't beat death, but you can't beat death in life, sometimes. And the more often you learn to do it, the more light there will be. Your life is your life. Know it while you have it. You are marvelous. The gods wait to delight in you. All right, with that being said, let's talk a little bit about heart disease. And I wanted to start off by saying I hate the title battling, because battling already puts us in fight or flight. And the thing about taking care of people with heart disease is this should be full of joy, should be lots of fun, and should always make us feel good. So while it may be a battle, it's one that we really should delight in as opposed to struggling with. Tonight, I'd like to talk to you about the State of the Union of Heart Disease. I gave this talk 1 year ago, and so I'm not going to repeat myself. A lot of the things I mentioned last year, not much has changed in certain areas, and there have been some exciting changes in others. What I'd like to do tonight is give everybody a quick reminder of what heart disease is, since that word is kind of a euphemism for lots of different things. I'd like to quickly remind you of the standard of care as it relates to our traditional Western approach to cardiovascular disease. I'm going to bring up what's new and exciting both on the national level and here locally. I'm going to remind everybody of our prevention strategies and lots of the things that you guys can do out there to make things better. I'm going to focus tonight on two areas that I think are really quite interesting and quite novel and really have become sort of more forefront in the last little bit. The first is a focus on what I call microstressors, or what are called microstressors. And I'd like to talk a little bit about the epidemic of loneliness, since I think that is a huge area of opportunity for all of you out there with me to make things a lot better. So I'd like to start off with just a quick anatomy lesson to remind you. This is a beautiful anatomic specimen made in wax from the 1600s. You can find this if you want next time you're walking around in Florence around the Porta Vecchio in a beautiful museum there called the Specula. What you can see in the center here is our heart, which sits right below the sternum. This is the lung out here. The heart is made up of muscular chambers, the ventricles and the atrium, which are the top and bottom chambers of the heart. And we have 4 sets, 2 on the top, 2 on the bottom. This main blood vessel is the pulmonary artery that takes blood from the right side of the heart to the lungs. This is the aorta, which takes blood from the left side of the heart to all the different parts of our body. What you can see on the surface of this heart are little squiggly lines here, which are the coronary arteries. This is the right coronary artery, which sits in the front of the heart. This is the left anterior descending artery, which sits on the back of the heart. And so when we think about heart diseases, what we're really talking about is many different organs within the heart. This is a similar anatomic specimen from the 1600s. It shows the heart in its sac, the pericardium, which also can be a focus of disease. And you can see the ribs and the muscles, which form the chest cavity, and also can participate in cardiovascular illnesses. One of the things I'm going to bring up tonight is that the brain is also a big part of cardiovascular health. We're going to talk a little bit about the heart-brain connection as it relates to both microstressors and loneliness. As I always say, no one writes poetry about the elbow. The heart and the brain really are the centers of our soul. And the heart and the brain are directly linked through the sympathetic nervous system and the parasympathetic nervous system. Now, the endocrinologists out there and a lot of our functional medicine physicians will tell us that it's not just the heart and the brain, but it's also our adrenal glands. So we'll have to include that as we think about heart disease and cardiovascular medicine, since the adrenal gland can secrete stress hormones, and particularly epinephrine and then chronic steroids, which can also influence cardiac health. I want to focus a little bit now on not just the heart itself, but the arteries of the heart. And in today's world, where many of us are getting CT scans of our heart and our heart arteries as a part of a screening protocol, we're becoming more and more versed on these coronary arteries. So I think it's important a moment just to remind you of the anatomy. This is a CAT scan of the heart that we've done in the practice here as a screening tool to look for whether or not there's plaque building up in this heart that we see in front of us. This is the aorta right here in the center. We see the right coronary artery as it courses down between the atrium and the ventricle, and it gives off branches. This is our right ventricular branch. And this is the dominant right coronary artery. We also have the left main coronary artery, which is the most important blood vessel in the heart. When people talk about widowmakers and severe blockages, they're talking about narrowings in the left main artery. It has a branch that we call the left anterior descending coronary artery, which is the most important blood vessel. It courses between the 2 ventricles and gives off lots of different branches. And then we have the circumflex artery, which runs around the back of the heart. Not pictured in this screening picture is the posterior descending coronary artery, which runs on the bottom part of the heart. So with that kind of anatomy lesson, let's just briefly talk about what heart disease is and what it isn't. This is a list, a partial list really, in very general terms of the different areas that cardiovascular medicine pertains to. We have diseases of the heart sac or the pericardium, and this is traditionally called pericarditis, often caused by viruses or after we've received a cold, and can be quite painful, often mistaken for a heart attack. We can have heart muscle diseases. These are the cardiomyopathies or congestive heart failure type syndromes. This can include infiltrative diseases where things start to grow inside the heart muscle. These days, if you're watching the Super Bowl, you're seeing lots of commercials for treatment for amyloidosis or amyloid. This is an infiltrative process that occurs in the heart muscle and can weaken it. Viruses can influence the heart muscle. COVID has been implicated in cardiomyopathies and congestive heart failures. So we, as cardiologists, specialize in heart muscle disorders. We can have disorders of the heart valves. These are the parts of the heart that allow blood to flow one way through it. We have the aortic valve, the mitral valve, the tricuspid valve, and the pulmonic valve, and they can become either narrowed or stenotic, or they can leak and become regurgitant. We have lots of electrical abnormalities of the heart. The most popular these days is atrial fibrillation. Again, if you're listening to the Super Bowl or watching television, we see lots of ads now to warn people about the worry about atrial fibrillation. Lou Alcindor has become one of the spokesmen for a medicine to help people stay safe with atrial fibrillation. And again, very popular in the lay press these days are all the different forms of atrial fibrillation, and we'll talk briefly about some of the options for treating them and some of the new fun things that we have available to us. Heart artery disease or coronary artery disease far and away is the most common. We're going to spend a fair bit of time talking about that here in a minute. We can also have problems of the great vessels. These are of the aorta in particular. Marfan's disease or aortic dissections, where the great vessels can tear or become damaged. These are quite painful, often catastrophic, but can be identified with screening and have excellent outcomes if we know about them ahead of time. And then again, since we're going to focus a little bit today on loneliness and some aspect of microstressors, there are brain-heart connection abnormalities. These are the disorders where the brain tells the heart to go faster or slower inappropriately, or the brain and the heart aren't communicating when we change position and we're dizzy. POTS is a very common example of these brain-heart connection abnormalities. And we'll talk more about that as the evening goes forward. Common symptoms of heart disease are important to address. The most important symptom is none. And so cardiovascular disease, especially in its earliest stages, can be silent. We know blood pressure can be silent, coronary artery disease, valvular heart disease, even weakening of the heart muscle can be silent initially. And so it's important, and we'll stress this again in a minute, to have a great relationship with your primary care providers so that you can be screened and appropriately evaluated to see if you're at risk or are having early signs of these disorders that we should know about early. Obviously, the biggest symptom that we're all concerned about is chest pain or pressure. Shortness of breath is common. Palpitations, dizziness. When I think about all these things, it's really an inability to perform life. So we try to do our activities of daily living and we just can't. Again, a very common symptom as it relates to heart disease. We can develop swelling of the lower extremities and just a general sense of fatigue. Now, one of the common misperceptions, and I just want to address this straight away, is that women don't have different symptoms than men as it relates to heart disease. And in fact, it's often said that women more often than not have fatigue or nausea as their primary symptom. And I just want to be clear about what that really means. So women and men typically are the same as it relates to cardiovascular disease symptoms. They have chest pain the same, they have shortness of breath the same, they have dizziness. In fact, the most common presentation for a woman with cardiovascular disease is chest pain or chest pressure. Now, in the group of people who don't present with our typical symptoms, there are more often women than men. So that's where this misperception comes from. It's not that women have different symptoms, they have the same, but when it's weird, there are more women than men. So we should have a high index of suspicion, but more often than not, the symptoms are the same. When we think about evaluating patients with cardiovascular disease, the standards are still the same. There is nothing new. Evaluation for cardiovascular disease requires a team, and the most important member of that team is your primary care provider. They can provide a history, they can do a physical examination, they can do a baseline EKG and laboratory tests. And these are often enough for us to be able to screen any kind of individual for underlying cardiovascular disease. Additional tests may be ordered, and we'll talk about that in a minute. But these sort of four principles are really important and form a great foundation and can be performed in all of our primary care providers' offices. So I want to focus now on coronary artery disease because it's the most common. a lot of times when people give these type of talks, they start off with the scary things, like how many people die of heart disease and how many people get a stroke, all these different things. And it really drives fear. And I am not fear-based, as many of you know. And so I want to start out by just saying, cardiovascular disease is really common. And coronary artery disease is the biggest part of that. More than likely, it's something that we're going to die from in the United States. If you don't die from coronary artery disease, it's likely to be cancer, and if it's not that, it's likely to be stroke. But the answer is nobody gets out of this alive, and as Charles Bukowski said, we should live our life fully so we don't have to worry about it. So we'll just get that out of the way. Nothing to be afraid of. The answer is yes, you're going to die. So we'll just take care of that straight away. Coronary artery disease is really common, however. And it's caused by an injury to the blood vessel lining. What you see here on this slide is an artery that's been sliced. And this white area right in the center is where the blood travels. That's called the lumen, or it's the channel. And what we see in this artery is all the different layers. We see a little brown squiggly layer that we call the endothelium. It's like Teflon, and it lines the blood vessel. In the pink, we see the muscle of the artery, and it's a muscle just like our bicep. It can contract and relax. And then out here, this pink fluffy stuff is called the adventitia, and it's the support for the artery. It's also where a lot of inflammation occurs. And so the natural progression of heart disease is that this endothelium becomes scratched or injured. There's an injury to this blood vessel lining. Inflammation occurs at that site. And then LDL cholesterol starts to deposit in the injured blood vessel and forms a plaque. And if you look right here, this is a plaque starting to form on the inside of this blood vessel. Over time, these plaques grow and grow and grow. And then ultimately, at some point in time, they rupture. And a blood clot will form. You'll see that happening here. And it will block the blood vessel. And that's what causes a heart attack or a stroke. So this process, which is slow in some people, fast in others, is the natural history of coronary artery disease. An injury to the blood vessel, inflammation, deposition of LDL cholesterol in these plaques, the plaque rupturing or calcifying, and then a blood clot. And so our strategies to treat and prevent heart disease are focused on this process. We'll just let that run through one more time, just so everybody gets a good feel for this plaque and how it ruptures. And here is the rupture right here, and a blood clot forms. So coronary artery disease is still managed in the same way that it has been since I became a cardiologist. We have two broad groups. We have an intervention group, which includes angioplasty and surgery. And we have medical therapy, which includes a collection of medications. The medications are tried and true. There's lots of debate. We have aspirin. We have the group of medicines called statins, much loved, much hated. But I want you to know that these medicines have been around now for over 50 years, came to us from Chinese medicine, and Mevacor, which is the natural statin, you could grow in the backyard if you could ferment white rice. We have ACE inhibitors, which are blood pressure medications, which can reduce plaque. Beta blockers, which reduce death in people with heart disease. We have nitroglycerin and nitrates to open up blood vessels. And then we have a collection of drugs which are relatively new to help get cholesterol out of these plaques. Zetia and the newest kid on the block, PCSK9 inhibitors. These are called Repatha or Praluent or inclisiran, and these new agents are really revolutionizing how we can manage this plaque process in blood vessels. There is also a new group of medicines, the GLP-1 agonists. These have been made famous by the Kardashians because they also can be used for weight loss, but they, in certain people, reduce cardiovascular risk and can treat heart disease. And so a new agent in our armamentarium. This is an angiogram just to show you what plaque looks like. On an angiogram, we can see a stenosis here in the main artery. So what's new in our armamentarium? As I showed you a minute ago, these arteries become inflamed when they become injured. And so for a long time, we know that inflammation has been a big part of the cardiovascular process. Traditionally, we've used statins as the anti-inflammatory to reduce that inflammation. What we've learned in the last year is that a very old medicine called colchicine, which has been used for gout and is a very potent anti-inflammatory, can be beneficial in reducing cardiovascular events in people where inflammation is the driving feature. The LODO-CO2 trial was published this year, which showed benefit to colchicine over placebo in treating people with cardiovascular disease, especially those in the group we call secondary prevention. These are people who have had a heart attack or had bypass surgery. So colchicine is now being used as a preventative agent. We also use colchicine in pericarditis, where there is inflammation of the heart sac. And we know that if we treat people with colchicine, we can prevent a recurrence of that pericarditis. So an old medicine with new tricks, and incredibly important in our armamentarium. We decide who needs colchicine based on a blood test called a C-reactive protein, which is a marker of inflammation. What else is new? Well, niacin is a really interesting medicine. I've been practicing now for about 32 years, and when I was a baby doctor all those years ago, some of the senior physicians used to say, never be first on the bus, don't be last on the bus when it comes to new and different therapies. And if you're around long enough, you'll see things come and go. And niacin has been one of those agents. Niacin is something we have always wanted to work. It's a B vitamin. It seems like it would be very benign. And so there have been lots of attempts to show niacin as being beneficial. Just in the last month, we've had a very important study looking at niacin again. And it's now the second one that suggests that niacin may be harmful. It may promote inflammation and predispose people to stroke and future cardiovascular events, such that niacin really is something we shouldn't use as a preventive strategy, either as primary prevention or secondary prevention. And if you are not sure about it, it's something really to discuss with your physicians. So a big warning out there about niacin. I mentioned the GLP-1 agonists, the Wegovy's, which are out there. These are really interesting agents. They work in the brain. And again, we talked about the brain-heart axis. It convinces the brain that we're not hungry anymore. And as a result, we get we can get weight loss. It can also help lower blood sugar. We know that insulin is a very big driver of inflammation, and so this is an anti-diabetic medicine. But given to people who have significant cardiovascular risk and obesity, this agent can reduce future cardiovascular events. We have used protein-based screening to decide who is at high enough risk where these medicines make sense, but these are being actively prescribed and incredibly beneficial in the right patients. What also is new are these PCSK9 inhibitors, Repatha and Praluent, and the most recent one, inclisiran, which was also at the Super Bowl. Inclisiran is really interesting because it's a twice-a-year therapy for something that some of us take pills every day for. And is really the beginning of what I consider a vaccine for heart disease. These drugs work by enticing the liver to cleanse the blood of LDL cholesterol. With them, we can achieve very low LDL cholesterols, almost in the single-digit range for certain people. And in many of the trials, we see significant regression of atherosclerosis on the order of 27% over 2 years. And so if we can detect heart disease early enough in certain people, we have the opportunity to potentially cure them of this process. And I say that not lightly, since that is something I have never ever thought I would ever get to say, that we would have a treatment that basically could get plaque out of blood vessels. So incredibly exciting. And these treatments, while very expensive and relatively new, are really becoming a mainstay in our armamentarium, especially in those people who cannot take statins. So, In broad strokes, when people present unstable as it relates to their heart disease, they show up in our emergency departments with heart attacks, they start with strokes, they're having an acute problem. Our medical therapy is not as good as an interventional option. And so it's why I came to Boulder Community Hospital almost 2 decades ago, or over 2 decades ago, because this hospital has been committed to a primary interventional strategy for our community members with heart attacks and strokes. So what does that mean? When you arrive in our hospital here with problems and we think they might be related to a heart attack, we immediately do an angiogram and we try to fix the broken blood vessel with stents if possible, and if not, surgery. And that approach is superior to any medical therapy and has stood the test of time. Now, where there's lots of controversy, and again, even in the last year, continues to be controversial, is what about people who have heart disease who are stable or don't have any symptoms? They're able to run the Boulder, do the Leadville 100, and yes, they have plaque in their blood vessel, and maybe they even have a stenosis. Well, it turns out in those people, you actually cannot show that angioplasty or interventional approaches are better than medical therapy. There are certain groups where that's not true, but in many groups, medicine is just as good. And so we have to start to move away from what I call the oculostenotic reflex. So when I first started out in medicine, when I saw a blockage like described right here, I said, this has to be fixed. We need to put a stent in it. An oculostenotic reflex. You see a stenosis, it needs to be feared and it needs to be fixed. And I still see people in the office who say, you know, doc, I had this CAT scan done. It says I have an 80% stenosis. I feel great. You know, I need a stent or do I need surgery? And the answer is no. So we can't yet show in stable patients or those that are asymptomatic that angioplasty and stents and even surgery are better than medical therapy. And that fixing a blockage, fixing a stenosis improves outcome, that we don't know yet. And so hopefully over the next years when I get to give this talk again, I can talk more about this or I'll have better answers. But at this point in time, we need to avoid the oculostenotic reflex. We have to avoid being afraid of stenosis, and we have to stop thinking about stenoses. We need to think about the fact that we have plaque in our blood vessels and that we need to get it out if possible and for sure make it stable. So enough said about coronary disease. I want to turn our attention briefly to heart valve disease, mostly because Boulder Community really is becoming it's really a national leader in the new and different approaches for these different problems. When a heart valve leaks, this is a mitral valve, which you'll see here with this blue flash is leaking terribly. We have traditionally done open heart surgery for these, but under the direction of Dr. O'Hare here at Boulder and others, surgery for this particular problem is really the state of the art. It can be done robotically, which we are leaders of here in Boulder. There's standard surgery, and we have several outstanding mitral valve surgeons who are true artists as it relates to fixing this valve. Most mitral valves these days should be repaired and not replaced. We are really at the advent of fixing these valves from the leg percutaneously without surgery. This includes both transcutaneous aortic valve replacement and mitral valve replacement. And Dr. Iyengar is leading our attempts or our team doing what's called the mitral valve clip, where we can actually repair this valve without surgery. These are really incredibly exciting. If you'd asked me when I started my career, would we be able to fix valves without having to do surgery, the answer would have been no. And now it is the standard of care, especially in the aortic valve. Structural heart disease, diseases of the different walls of the heart muscle are also becoming more and more common as adults with congenital heart disease reach adulthood. Dr. Iyengar leads our structural program here. These can be all repaired using different devices from the leg without having had open surgery. We are also leading the way as it pertains to the Watchman, which is a device used to prevent stroke in those of us with atrial fibrillation. Our team, this is an example of a hole in the atrium of an adult that needs to be closed. This can be done with a clamshell device from the leg. This is a cartoon with the newest device, just FDA approved. This is a tricuspid valve repair device. It's a tri-clip which can be placed in the tricuspid valve from the leg and then used to shore up the tricuspid valve leaflets. This was just FDA approved, and again, an exciting approach to valvular heart disease, which was unthinkable a decade ago. I did just want to call out Dr. O'Hare, who is actually he's the director of Boulder Heart, but also director of the robot program here. He has led a number of national studies and really has been one of the leaders in showing that the new valves that we put in from the leg are durable and are as good as our surgical valves. I also wanted to call out Dr. Iyengar, Dr. Ware, and Dr. Lyle, also members of our structural team. They put the first in Colorado Watchman Flex device in just last week. This is a new device, again, that we use to prevent stroke in certain people with atrial fibrillation. So a big problem in cardiology these days is heart arrhythmias. And we struggle with atrial fibrillation as the sort of vanguard of these irregular heartbeats. These days we all have our Apple 8 watch on or Apple 9 watch. It has wonderful algorithms to detect atrial fibrillation, so we're finding more and more people with this disorder. Our current treatment really has included medications, which are lousy, ablation, which is really coming into its own, and in those people where that fails, we have a surgery for atrial fibrillation. The focus of our interventional treatment has been on the isolation of the pulmonary veins. These are 4 veins that enter into the back of the heart in the left atrium. We know that if we can electrically isolate them, we can reduce the risk of AFib by like 70%. That's what a successful ablation is about. Traditionally, we've used either heat or freezing techniques to isolate each of these veins. What's really new in the AFib world and just recently approved by the FDA is a new energy source to isolate each of these pulmonary veins. It's an electrical energy, and what we do is we have a special catheter that we can put in each of the veins through the leg, and we apply a little electrical current to these veins, and that is enough to disrupt the tissue around these veins. What's exciting about that is the side effects of ablation therapy, because we heat things up or cool them down, are injury around the heart. This reduces that potentially. It also allows the procedure to be done much quicker. So a typical AFib ablation these days is several hours. In Europe, where this new energy technique has been used, they can do these ablations in about 45 minutes. Because it happens so much faster and may be safer, this is allowing ablation to move forward in our strategy in those who have an episode of atrial fibrillation. More often than not, we waited until people had multiple episodes over multiple years before we considered it. And it's really moving towards the forefront as a first strategy as it relates to atrial fibrillation. So I'm going to come back to coronary artery disease to talk a little bit about prevention, and again, talk a little bit about microstress and loneliness. So in coronary artery disease, we know what the standard risk for having it is. Hypertension, smoking, elevations in cholesterol, ApoB, which is commonly measured these days, which is a more accurate measure of LDL cholesterol. Lipoprotein little a, which is a special protein in those of us with strong family histories. Diabetes, the fact that we're getting older, males versus females. We often can use an ASCVD risk score to sort of determine what the likelihood is that we have heart disease and could be injured from us. And this allows us to sort of focus our preventive strategies. Now, you guys have heard lots of talks, and even this year, treatment for hypertension, cholesterol, we know what that is. We need to stop smoking, we need to eat more fruits and vegetables, and we need to exercise more. So I'll just sort of leave it at that. Those are the things that we need to do. Tonight, I want to focus on some of the things that are not so common, that we don't really think about that much, but I think are almost equally important. These are some of the social determinants of health. They include mental health, and really something that's very important to me: depression, anxiety, isolation, neglect, addiction. These things all contribute to cardiovascular disease. Our employment status and our insurance, or our worries about money, can lead towards increased cardiovascular disease. Our educational status contributes to heart disease. Access to care, for those of us that don't want to come and see the doctor, that can contribute. Obviously, nutrition we've talked about, and our environment. We're fortunate enough to live in Colorado, but there was a time when living in Denver was a risk. We had the brown cloud. Pollution, all of these things contribute. I'm sure microplastics do, but we just haven't seen the data yet. So these are all things that contribute to our overall health. We talked recently, one of the things that's really important is if we're concerned about whether or not we have atherosclerotic cardiovascular disease, you can be screened. The heart scan is 99% sensitive at detecting plaque in blood vessels. And so if anybody asks me, do I have plaque, we can take a picture and answer that question. I did want to just address briefly that calcified plaque is the tip of the iceberg. Underneath the water is soft plaque, fibrotic plaque, which is not measured by calcium scores. And so while these scores are really important, they don't tell us the whole picture. We know that if you have a 0 score on a calcium test, the likelihood of having an event, a heart attack or a stroke, in 10 years is about 1 in 1,000. With a score of 0 to 100, that risk goes up to about 8%, and greater than 100, there is a logarithmic relationship. And so based on these risk scores, we can design preventive strategies. It's not the state of the art, though. These days, CT-based angiograms allow us to see both the hard and the soft plaque, and allow us to quantify both the blood flow through them. This is a 3-dimensional picture we made from our CAT scanner. And using new modalities, artificial intelligence from a company called Clearly or HeartFlow, we can look at each artery and see both the soft plaque, hard plaque, fibrotic plaque, plaque that is amenable to regression, and plaque that isn't. And so these new modalities are really allowing us an intimate view of each of the arteries and helping us define strategies. So what can be done? Again, quit smoking, blood pressure under control, lower our cholesterol, treat our diabetes. We need to exercise, and for those of you who know me well, I don't believe in exercise, I believe in recess. We need to twice a day get out and run around and skip. 10 and 2, the bell goes off, we put our pencil down, we go out and play. We need to eat more fruits and vegetables. We're going to talk a little bit about alcohol at the end if we have time. We need to address obesity, and we need to talk about stress. So microstress. So we all know about big stress, right? Somebody pulls out a gun and threatens us. We get in a car accident. Those are stressful events. More often than not, we resolve those. We have a freeze, fight, or flight reaction, and they finish. What isn't finishing, especially in today's world, are microstressors. And we have millions and millions of them all day long. They are so subtle we don't even appreciate them. These are small moments of stress that are manageable on their own, but over time add up. These are the little hassles of every day. They are the passive aggressiveness of our teammates. They are the television playing the news. There are telephones when the email goes off, or we see a flash from Facebook. All of these little elements can build up, and through the heart-brain axis, through our adrenal glands, they can cause repetitive injury and predispose us to cardiovascular events. They deplete our emotional reserves. They're responsible for burnout. They keep us from getting things done. I know that when I appreciate my micro stress is really building up, I become paralyzed. I'd rather sit on my couch looking at my phone. And they really challenge our identity. And they really can take a toll on our health. And they have real measurable effects by increasing heart rate, increasing blood pressure. They can cause peripheral vasoconstriction and inflammation. And we really need to start talking about this. So what are some of the strategies? Well, lots of things that we've talked about. Reducing screen time, exercise, really just becoming aware of these microstressors and becoming mindful, taking a breath, really having recess at 10 and 2. All of these things start to address these microstressors, and we'll have a better outcome as it relates to cardiovascular disease. I wanted to take 1 minute to talk about food because people who I care for know that I have evolved over the time, and I guess that's why it's called the practice of medicine. We're never quite stagnant. And my current concern is about real food. We know that Michael Pollan, who wrote The Omnivore's Dilemma, talks about real food, mostly plants and not too much. I am mostly concerned about processed foods. I was on an airplane recently, and I was in first class, and they gave me a all butter croissant. And croissant, as those of you like to cook, should be butter, flour, and water. These are the ingredients in my butter croissant. Enriched flour, malted barley flour, niacin, which we know is bad for us, reduced iron, thiamine, mononitrate. I can't even say all these things, but clearly not the big three. And so I would advocate to you tonight that as we think about diet, moving towards whole food plant-based or Mediterranean, I would really focus more on real food. So look at the ingredients. If there's something on that list that you can't name, don't eat it. I want to close with loneliness and isolation. It's clearly an epidemic. The U.S. Surgeon General actually put forth a task force as it relates to this, especially in the COVID and post-COVID era. It's important to understand that if in our people who are lonely and isolated, the risk for premature death increases by about 26 to 30%, depending on the study. There is a 30% increased risk of heart disease, a 32% increase of stroke. The current spending based on isolation and loneliness alone is about $6.7 billion. And if heart disease and stroke aren't enough, about a 50% risk in increasing, or 50% risk of dementia over baseline in those people who we define as either isolated or lonely. When we look at how we're doing over the last couple of years, and we look at a variety of different categories, we're not doing very well. Social isolation going up, household family social engagement going down, companionship going down, special engagement with friends plummeting, non-household family social events going down, and special engagement with others going down. We are becoming more isolated and more disconnected, and it's having an impact. Lacking social connection is about the same as 15 cigarettes a day. So we talked about cardiovascular risk. This is worse as it relates to cardiovascular health. When we compare it to other things like drinking 6 alcoholic drinks a day, being a slug and inactivity, obesity, and air pollution, this is far worse than those things. And so it really requires our attention. There are lots of factors that shape our social connection. Some of them are on the individual basis. Some of them are community-based. Some of them are societal. But I think it's something that we really need to talk about. And we'll talk a little bit about what Boulder is doing. I know personally, especially in the post-COVID world, re-engaging with friends, re-engaging with family is critically important. How does this work? Well, the biology is pretty straightforward. In people who are isolated and lonely, there are increased stress hormones that causes inflammation, which we know causes events. Get out your colchicine. Psychologically, people don't move as much. There's more stress. They feel unsafe and fearful. And then, of course, being isolated and promotes bad behaviors. We're less physically active. We don't eat as well, or we go to McDonald's or fast food. And these all contribute to our poor outcomes in health. The Surgeon General has asked us to address at least 6 pillars as it relates to social connection. We don't have time tonight to go through them individually, but suffice it to say, this has to occur in communities, in families, it's critically important. Some easy answers from my point of view. These are just some examples of community events that we can do in our community here in Boulder. There's church, there's Rotary, there are the senior centers, there's book groups. We can join communities that exercise together. This just reminds me, this is my tribe, this is my brother-in-law. We fence together with my son and my nephew twice a week. Here's CU supports Go Buffs. Call out to my dinner club mates. We go out to dinner once a month to share stories and vulnerabilities. All of these things participate and keep me safe and healthy. And I'd encourage you guys out there to do the same. Boulder is trying to do the same by recreating our community. There are 2 really great options. We have a heart healthy nutrition and lifestyle class that's sort of forming here. It starts in about 2 weeks. I'll try to put this up at the end. We can also send out a notice to everybody. Again, it's a group of people getting together to talk about nutrition and cook together and maybe even exercise together. The Boulder Parks and Rec Center are tremendous. They have a cardiopulmonary maintenance for those of us with cardiovascular disease. Again, a great community to exercise with. I want to encourage us all out there not to give up. Lots of reasons why people give up. They expect fast results. Cardiovascular disease takes a long time to develop and a long time to reverse. So we got to go slow and easy. Stop believing in themselves. They get stuck in the past, dwell on mistakes, fear the future, resist change, give up their power, believe in their weaknesses, feel the world owes them something, fears failure more than success, never visualizes what's possible, feel they have something to lose. We feel overworked, too much microstress, assume their problems are unique, which they're not. And being in community can allow us to share our vulnerabilities. See failure as a signal to turn back when it's really an opportunity, and we can feel sorry for ourselves. But this is something we can do different things about, so don't give up. I'm going to stop with a quick breathing exercise because one of the things I do, especially when I'm feeling stressed or micro-stressed like I am now at 55 minutes into this talk, is to take a deep breath. The last time I gave this talk, I taught a simple breathing technique that we could do to help bring down our nervous system, bring down our sympathetic nervous system and increase our vagal tone. It was the single nose breathing. So we would put our finger on one nostril and breathe in and breathe out, and 3 breaths on each nostril. I'm going to teach you a second one tonight, which is also helpful in calming the sympathetic nervous system and bringing up our vagal tone. And I'm just going to show you, and then you guys can try it at home. And I'm just going to put a finger in my ear, and I'm going to push down on that little tiny button there. We call that the tragus, and I'm just going to give it a little bit of pressure. And I'm going to close my eyes and just take a big breath in and breathe out. And just with that, I can feel my micro-stress drop just with one breath. So 3 of those, 1 in each ear, should help bring things down. With that, I'm going to stop and answer some questions. I will say tonight is always weird speaking to myself here in this room. I grew up in Washington, D.C., and there was a television show when I was a little kid, and it was kind of interesting. It was on television, and the woman who was for children, and she had a little mirror that she would point out at the end, and she would look through it into the television, and she would say, "I see Johnny out there," and all the different people. She would just name people who were out in the community. It was called Romper Room. And so I do want to shout out to all the people watching tonight who I know and who I don't know. Definitely want to shout out to my my dinner boyfriends who we go out to dinner with. I know they wanted to razz me tonight and throw tomatoes and all, but I know they're out there supporting me, and I appreciate that. And with that, I'll stop and answer questions. Thank you.
Thank you very much, Dr. Trujillo. That was just jam-packed with information. And we do have a lot of questions that have already rolled in.
Okay.
I want to remind our audience that now is the time for questions. You can ask them. We will get to as many as we can. We've got about 10 minutes now. And these are in no particular order.
Okay.
How do these blood vessels get injured to have coronary heart disease?
Excellent question. These blood vessels have a lining. It's a lot like Teflon in our Teflon-coated omelet pans. They get injured by being scratched. So actually, it's really a damage to this Teflon layer. There are many things that we know cause these injuries. So smoking can do it, an acute fatty meal can do it, pollution can do it. There are, I don't know how many different things that can injure these blood vessels, and it's a cumulative injury. In any one individual, what caused that particular injury is unknown. And so there's not like a signature, but there have been all the different risk factors that we know about cause injury to this endothelium. That's the name for this Teflon layer. That scratch is the initial insult. We can actually see it in children as young as 2 years old who die from other reasons. When we look at autopsy, we can see these fatty streaks in their aortas, really common in teenagers. So the injury process starts early, and I think many people believe it's part of our industrialized life. It's what makes us Americans, I'm afraid.
Okay. Can a heart diagnosed with heavy coronary heart calcification still have some normal heart flow as seen in a nuclear stress test?
Absolutely. So just to put this in perspective, we talked about calcium scores of 0 to 100. The highest calcium score I've ever seen is 6,700. And I've known that person for almost 30 years. Nothing has ever happened. He's had normal angiograms, normal stress tests, lived a normal life with nothing ever happening. And we put stents in people with scores of 1 or 2 where these plaques become unstable. And so this idea of heavy calcification or heavy blockage is worse than less than that is just not true. There's not a linear correlation necessarily between these numbers, these stenoses, and what happens to people in their life.
Okay. Please remind me, when is the drug mavacamten used?
So mavacamten is a new drug. We talked a little bit about that last year. For people who have a problem called hypertrophic cardiomyopathy, this is where heart muscle starts to grow uncontrollably. And as the muscle grows, it starts to, the cavity where the blood lives in the heart gets smaller and smaller. And ultimately, the muscle gets so thick, blood can't get out of the heart. And so mavacamten is a new medication which allows the heart muscle to shrink. It's only given now in selective centers. There are only like 4 or 5 in the country. But there will be new agents coming, and it offers an alternative to surgery for families or those with hypertrophic cardiomyopathy.
Okay. Why is a heart scan important if the score is incapable of telling me if the plaque is soft or hard before prescribing a statin?
So if a calcium score is positive, we know that there is both hard that we see and soft that we don't. And so, yes, it's true, there are other tests that might give us more information. The presence of calcium starts the process of prevention. So many times that's sufficient to start, and statin therapy isn't necessarily 100%. Even with the calcium score. It's a discussion for sure if there is a positive number. In people with a calcium score of 0, and these are generalizations, they often don't need statins. Between 0 and 100, there is an opportunity to do lifestyle as well as statins. One is not necessarily better than the other, and then greater than 100, we almost always prescribe statins or other agents. So I think that calcium scoring is an exquisite tool, very sensitive at detecting people with heart disease, and it's cheap. So a calcium score these days is $175. A CT angiogram with clearly can be $1,000 or more. And so I think from a cost effectiveness point of view, it's an exquisite test.
So when would you do the CT angiogram?
So CT angiography is used now in high-end screening. So in certain people with certain family histories, or if you were to go to the Cooper Clinic or some of these very high-end screening programs, CT angiography is done. I use it in two groups of people. I use it when we are afraid, and so in people who have heart disease or a positive calcium score where they have symptoms or there's concern about whether or not they can exercise, or whether or not there's a quote-unquote ticking time bomb, or we're just afraid, a CT angiogram allows us to see exquisitely exactly what's in there. And we use that to relieve anxiety and fear. It can be used in people with unusual symptoms, and we want to see if they're attributable to heart disease. And again, in the screening world, the Clearly labs can be used every year to show that our medicines are working. We don't know yet from a scientific point of view whether that's a better approach than just treating people with medicine. That's more to come.
Okay. After several heart events, my doctor suggested I use the Repatha injectable to lower LDL to 0. Your thoughts on Repatha in this path?
Well, Repatha is superb. And in people who have failed statins, in the sense of having events despite being on them, or where we can't get their LDL cholesterol as low as we need to, Repatha is superb. Our current goals for LDL cholesterol are 70 in the United States, 50 in Europe, and soon to be 30. And there are people advocating for single digit or 0 LDL cholesterol. And so I think your doctor is being wicked aggressive, and I think that's awesome.
Okay.
I'm channeling my inner Boston there.
Are there any well-controlled studies evaluating whether components of diet restrictions for your to get your cholesterol and fat in line have any adverse effects on a person's health, heart health?
So there are diets that have adverse health effects as it relates to heart. The Atkins diet, the paleo diet have adverse cardiovascular outcomes associated with them. Now that being said, they're excellent weight loss diets, and there are times we use them. And all of these trials, every diet trial that has been done is an observational trial and self-reported. And so we're never going to have, or at least not probably in my lifetime, hard evidence one way or the other. We just have large trends. So the beneficial diets in heart health include the Mediterranean diet, and that's how people ate in Crete in the 1950s. Ansel Keys is the person who did that. The DASH diet, DASH, which is the American Heart Diet, and then whole food plant-based diet, or veganism, I guess would be that description. All of these things share a couple of things. One is real food, so no processed food, which I think is much more important, and really a restricted amount of calories.
Okay. So some lipoprotein questions.
Yeah.
What is the latest treatment for high lipoprotein and calcification of the arteries, especially for someone that already does all the lifestyle factors and is pretty much healthy?
It's awesome. So lipoprotein little a is getting a lot of attention these days. Inclisiran, which is one of the new agents, can lower lipoprotein little a. We don't know yet that has a beneficial outcome in the future. We have tried to lower lipoprotein little a in the past, and it's not been shown to be very good. ApoA is what defines HDL cholesterol. There have been a number of attempts at making ApoA go up, raising HDL cholesterol. Those have been negative trials. They've caused more harm. And so we are not treating HDL cholesterol at the moment, though there may be a suggestion that, we used to think that the higher the HDL, the better. That might be true to a point. There are probably people whose HDL cholesterols are extraordinarily high where that's not helpful. ApoB protein is basically the European way that they measure LDL cholesterol. So an LDL cholesterol particle has an ApoB protein that marks it. So some of us don't worry about the LDL cholesterol as much as ApoB. The treatment for that is the same. It's statin therapy or PCSK9 inhibitors or diet. So those are the lipoproteins that we're treating specifically at this point.
Okay. We are about out of time here, but want to get in a couple more questions here.
Yeah.
What is on the horizon for reversing atherosclerosis, if anything?
Well, I think that the PCSK9 inhibitors and the agents like it are really the current frontier. I think our delivery systems right now, those are all shots. Again, inclisiran, it will be a twice-a-year shot. There is a preliminary mRNA. I think genetically we'll be able to sort of make our body make these drugs, and so there will be a genetic fix or a gene fix on the horizon. I do think if we as a society decide to sort of go back to eating like we did in the 50s, we have a chance as a society to really reduce the risk tremendously. But that would be take a lot of social and political pressure to do that. So I think that those are the big things on the horizon.
Is edible cannabis harmful to cardiac patients?
I am neutral. I have no idea.
Okay.
I guess if you have it in butter, maybe.
Is there some correlation between severe sleep apnea and heart risk?
Yeah. So sleep apnea poor sleep is a cardiovascular risk factor. I didn't mention that tonight. I should have. So poor sleep affects lots of different aspects of health. There is an association between sleep apnea and sudden cardiac death. We don't have studies that show that treatment necessarily changes that outcome, but sleep is something really important to address with your care team.
Okay. And real quickly, can you briefly explain the general pros and cons of taking statins?
Oh, wow. That's more than a 5-minute discussion. So what are the pros? Taken all together, statins are the only thing I know that reduce inflammation, are antioxidants, lower LDL cholesterol, and ultimately reduce cardiac events. So as a treatment for cardiovascular disease, bar none, probably the most important treatment that I've had in my lifetime as it relates to taking care of people with cardiovascular disease. What are the harms? Well, the harms really are I would say none, in the sense that there aren't deaths associated with statin therapy. People can develop muscle aches. There are rare people whose muscles become inflamed. They are incredibly well tolerated. They are cheap. $4 for a prescription these days for 90 days, and really are pretty powerful agents. When I think about, let's say, alcohol or red wine, I'm going to drink red wine for heart disease prevention. I mean, last year there were 60,000 deaths related to alcohol in the United States. There were like no statin deaths. So it's hard to be angry at them. Now, that being said, we're Americans, we have cognitive dissonance, we want to hate them. And there's a lot of bad press about them. Nobody writes the blog, took statins, nothing happened, but we all know somebody or talk to somebody where the statin caused muscle aches and they had to stop them. There are 12 flavors. I haven't had to go through all the flavors in getting people on the medicine who need it. There are alternatives, so I think there are always other options. But when I think about any medicine that you could put in your mouth, niacin, for example, they're pretty darn safe, pretty effective, and really pretty cheap.
Thank you so much.